part of the talk is coming to the CVI therapy. Firstly, I'd like to acknowledge Professor Leah Hyvarinen, the inventor of the Leah tools and everything that, and she's been mentoring our program at Narayan Nethralaya, and Dr. Namita Jacob from Chennai, and our own faculty, Pooja Sarbajna, who is our lead CVI therapist and CVI specialist. Dr. Karobi and others have covered the anatomy, so I'm really going to move out of that and try to go directly to how we classify in terms of for therapy. So this is just math, 2 standard deviations if it's under 1 stream, 2 stream, which means a motor, fine motor, a sensory, and so on. And then to majorly as ophthalmologists and as clinicians, we want to differentiate delayed visual maturation with cortical vision impairment. So even in DVM, there's something that will improve with the natural history and some that will take a little longer and may even have defects. So that's our job to, and the best way to check that out is the functional vision assessment that Dr. Himika and Dr. Anisha spoke about. So where we want to point out in simple words is there a problem in the child figuring out where the object is or what the object is? So the ventral stream, dorsal stream, terminology is not important, but if the child can look at, locate the object or figure out the object in terms of the spatial orientation, these are 2 distinct things, and there are of course tests and ways of doing that, and that will sort of give us a clue on where we need to take this baby in terms of management. So these are children from Dr. Namita's center, and then I'll share some from our own. These are children who have a lot of motor developmental delay, neck control abnormal. And so you have to start by assessing what they can see and what orientation they can see. And then of course they improve right from motor skills, because vision is so important, especially in the first 2 years. They say about 80 to 85% of all other milestones are dependent on how vision improves and progresses. So how do you identify the CVI child in your clinic? Well, vision is variable, peripheral, moving objects are much seen better than stationary. Color vision may be normal. Photophobia, as Dr. Karobi mentioned, about a good 1/3 of them are. They have a problem with depth perception, reaching out to objects. And of course, they're uncomfortable in social gathering, and they have a problem with crowding or clutter confusion. Very, very important in our setting seems to be hypoglycemia, even more than birth asphyxia, which is seen in the West, and seizures and others infections are there. So what we assess here is that, and probably this is one of my most important slides, in terms of history, the poor eye contact, staring at lights, poor visual inattention, tripping, cannot locate objects on the floor, finding it, for the older child, finding it difficulty to copy from the board, and so on. And everyone's put up these slides on how it has to be a holistic approach in terms of doing right from the tests that we do. And these are quick pictures to show you how all of these parameters are tested in our outpatient. And then, of course, after the assessment is done, one has to figure out what form of therapy is best required. So this is, for example, a baby who underwent ROP surgery for advanced ROP and had very little anatomical remnant of an attached retina. And this is Professor Leah herself in our center, who was assessing that child to figure out which is that field of vision, field of view that the child can be worked on. And using these parameters where we are assessing them before and after, we are able to make a very big change, not only in their vision, but also in their other milestones. I'm going to just quickly forward this. These are basically the video of all the skills that I showed you, and this is how the assessment is done. And we are all using the Leah tools, right from contrast to depth to visual field. All of that is assessed using the Leah tools. And once that is done, and you can see this child's behavior, movement in the clinic and so on, has so drastically improved. So let me quickly now go to the important subgroups have been spoken about, and we know that that is a, so yeah, so this is how we would manage these babies in terms of where they fit in. Since the pandemic, we have also started online therapies. So as Dr. Himika said, the first session is with us. In fact, the first 2 or 3 sessions are with us. And then after that, there are group therapy sessions and solo, depending on the age group. And they're all connected with our vision therapy and vision rehab specialists. And we are now helping to make them do these therapies, and then come once in about 4 to 6 weeks for reassessment, and then to decide whether they need to be moved up or require other therapies. In our center, we also have the speech therapist, the occupational therapist, the physiotherapist, a cognition specialist, and a pediatric neurologist, all on the same floor. And we're fortunate that we are now being able to provide a sort of holistic, as Dr. Garubi mentions, approach under one roof. And we hope that after the pandemic, this will become, we're trying to integrate with schools. As rightly mentioned, integrating it with inclusive education is becoming a challenge. And we have to work not just with the NGOs, but also with the government to make that happen. This is the summary of the principles and the therapy that we do that was published in Dr. Azad's paper recently. Thank you very much for the opportunity.